Welcome. I'm Tom McMillan from the Institute of Health and Wellbeing at the University of Glasgow. This film is an introduction to the use and administration of the Glasgow Outcome at Discharge scale. Further background and information on validity and reliability can be found in the Journal of Neurotrauma. If you want to download a free copy of the form and written guidelines, you can do this here. I'll tell you a little about the GODS and then we'll demonstrate its use. The Glasgow Outcome at Discharge scale, the GODS, assesses disability after traumatic brain injury in an inpatient setting. It is derived from the Glasgow Outcome Scale Extended, which assesses disability in the community, but cannot be used in inpatient settings. The Glasgow Outcome Scale is the most widely cited assessment of outcome after traumatic brain injury, and both the GODS and the GOS can be administered in busy clinical settings by professionals from a range of backgrounds. The GODS can be used in conjunction with the GOS to monitor disability in hospital and then later in the community after discharge. Both the GOS and the GODS are simple and quick to administer and are valid and reliable. People with a traumatic brain injury are often cared for in a range of acute hospital settings, including orthopaedic and general medical wards, where there can be limited training and expertise in the effects of brain injury. Sometimes people are discharged when physically able, but have undetected cognitive and emotional problems that require rehabilitation or care. An assessment of disability in inpatient settings with a simple and robust tool that can be used by non-specialist ward staff can help to address this problem in several ways. For example, it might inform decision-making about readiness for discharge, discharge planning, and clinical audit. It may indicate the need for specialist assessment or referral to allied health professionals or clinical neuropsychology, or the need for social work care assessment. If linked with the GOS, it might be used to assess change in disability across inpatient and community settings, including before and after interventions. In research and acute care, it may form a baseline to monitor natural outcome or outcome in response to treatment, or acts as a surrogate early endpoint that may, to an extent, compensate for loss to follow-up. Hence, we devised an inpatient version of the Glasgow Outcome Scale Extended, the Glasgow Outcome at Discharge scale, to enable assessment of disability after head injury in an inpatient setting, including by general ward staff who have been instructed in its use and need not be specialists in brain injury or rehabilitation. Before demonstrating the administration of the GODS, we will explain how disability is categorized. There are 8 outcome categories in an ordinal scale. 1 is the worst and 8 the best outcome. These are the same categories as found in the extended version of the GOS. The first 2 refer to death and loss of consciousness and will not be discussed here. The remainder consist of good recovery, moderate disability, and severe disability, and each of these has an upper and lower level. Details are also given in the written guidelines for the GODS. The GODS is a simple scale in which the patient's overall rating is based on the lowest category of outcome that's achieved. The categories are shown at the end of the form and each is assigned a number. For example, lower severe disability is 3. If returning to page 1 of the form, the outcome categories are found in brackets on the right-hand side of the form. First of all, note whether the patient is conscious. Defined here as able to obey simple commands, write or say any words, or communicate by other means. If they're not conscious, they're rated as not conscious with a category score of 2. You need to note in the form whether they lack responses because they've been sedated, or if they've been diagnosed as being in a vegetative state. If they're conscious, you then need to assess how independent the patient is in the confines of the ward. More specifically, this refers to needs for nursing care and supervision. If people need prompting to carry out tasks, they are more disabled than if they do not. A key factor is whether they can look after themselves for up to 8 hours during the daytime. And another is if they are confused. If, for example, someone was confused or required 8 hours or more of care during the daytime, they would be rated as lower severe disability. If the person is categorised as lower severe disability, the assessment can stop at that point. However, before you stop, it is important to judge what the person was like before the brain injury. If the person required 8 hours of care before admission and the same after injury, then the assessment needs to be continued because the GODS assesses the effects of brain injury that has resulted in the current episode of hospital care. We'll show you an example of lower severe disability using an actor. Remember, you should always speak to a member of staff that knows the patient well, and most often this will be a nurse. Normally do this first and then see the patient. You need to bear in mind that the patient may be confused or lack insight and may not give accurate information.
I was just going to see Stephen Johnson.
Yeah, that's him, been with us now for about 2 weeks.
Yep.
No recall of what happened to him, can't remember the events leading up to it being A&E, you know, what happened to him. Still a bit disorientated at the moment, you know, can't tell you his full name, his address, you know, what day it is, the ward number, etc. So still some problems with his orientation. Needs a lot of support in the ward with his ADL, needs 2 nurses with him at all times for things like dressing and washing, going through to the toilet. It has occasionally been incontinent. Really does at this point pose a safety risk at the moment because he doesn't take on board that he hasn't to get out of bed without support, so he'll try to get around the cot side sometimes.
Any idea of what happened?
Got this at home, it's a different colour.
Ah, right, okay.
It's not like as, just the pattern's all different.
Not as nice as that one?
Where's this one from?
I'm not sure actually. Do you know what happened to you, Stephen? Do you know why you're in hospital here?
No.
No. Do you think you had some kind of accident?
Yeah. I had an accident.
Okay. Do you know how long you've been here?
Who are you again?
I'm Elaine. I'm one of the research nurses.
Yeah.
Do you know the name of this place, Stephen? The name of this hospital that you're in?
No.
Do you know what day it is today?
Is it Friday?
It is, yeah. Do you know what date it is?
Is it May?
Nearly. Are you uncomfy?
No.
You're not used to lying in bed so long? Any idea of what year it is, Stephen?
That's for my mum's friend. They're going to have like a big party.
Do you mind if I speak to her? And then maybe come back and see you again in a few days? Okay.
For upper severe disability, the person would not function independently out of the ward, and they would not be confused. On the ward, they may be antisocial and irritable, but not severely disruptive. The third section of the form assesses independence when out of the ward. If the patient has not been out of the ward, it may be important to arrange for this to happen as part of the discharge assessment. Occasionally, judgment may be required when forming a view about the rating here. An example of an out-of-ward activity could be a visit to the hospital shop and the extent to which they can do this independently. A further example would be their ability to travel independently, perhaps to and from the hospital shop, or for a pre-discharge visit home, and the extent to which they need help with this. Once more, account needs to be taken of their pre-admission ability in these tasks. If unable to carry out tasks of this kind, they are rated as upper severe disability.
I mean, that's him been with us now just for over 2 weeks. Actually, he's quite orientated now. You know, we've found on a day-to-day basis, remembering his name, his address, where he lives, the ward number. So quite pleased about that. That's certainly better. Doesn't have any recall regarding the injury. Still needs a lot of sort of kind of reminding about what happened to him.
Right.
He's able to get up and around the ward fairly safely and unassisted. With his ADLs, he continues to need some prompting, some sort of structure into that. He would tend to lie in bed if we didn't say come up and get showered. He would not get shaved, for instance. He's also complained a wee bit of needing some help with doing things like buttons. So the OT had done some dressing practice with him and confirmed that, but that's getting a wee bit better. The OT also has had him down at the kitchen for a kitchen assessment where he was able to make some tea and toast. It was quite structured, but when she took him down to the shop downstairs, didn't do so well there. Needed a bit of prompting, didn't feel as though that he was sort of in charge of his money particularly well, waiting in the queue, etc. So that was a wee bit more challenging for him. So I think the outcome from her point of view was that he's okay for a period of time, probably throughout the day, but not within a full 24-hour period. She'd be slightly concerned with the need for prompting, etc. He's been up and down the stairs with a physiotherapist, relatively safe there. Generally, he's quite settled and quite compliant within the ward. Still complaining of some headaches, requiring regular analgesia for that.
Right, okay.
But otherwise, you know, doing
okay. That's great. Okay, I'll go and have a wee word with him and then maybe come back and catch you after I've spoken to him.
Okay, perfect.
Thanks,
See you later.
Bye.
Bye.
Was there a lot of people around?
Yes.
Do you remember being in an ambulance before you got there?
No.
None of that? Okay. Do you know what day it is today?
Friday.
Okay. Do you know what month it is?
April.
Do you know what year it is?
2013.
Okay, good. And do you know the name of this hospital?
Yeah, it's the Western.
Great. While you've been in the ward, have you been needing some help from the nurses to do things on a day-to-day basis?
Yeah.
What have they helped you with?
Getting out of bed, putting on clothes, taking off clothes.
Right. Other than that, once you're out of beds, can you walk into the shower by yourself or go to the toilet by yourself?
Yeah.
Are you quite safe? Do you feel quite comfortable doing that?
Sometimes I feel a bit shaky, but I'm getting better at it, I think.
Okay. Have you been down to the kitchen with the occupational therapist? Have you made a cup of tea and a slice of toast?
Oh yeah.
Have you done that?
Yeah.
How did that go?
It was okay. Yeah.
Did you manage to do it okay?
Yeah, I did. I made a cup of tea, and I think we did the sandwich together.
Okay. How do you think you would manage at home? Is there someone with you during the day?
Yes. Yeah.
Would there normally be someone with you during the day?
Well, at the weekends there would be. But,
Okay.
The next section relates to employment and the extent to which they can resume work at their previous capacity. Clearly judgment is required here, but bear in mind that if the patient is about to be discharged, then they may need to have advice about return to work. The categories in the rating scale are fairly broad and refer to return to work as pre-injury, in a reduced capacity, or not able to work as before. If their work capacity is reduced, they are rated as moderately disabled.
I was just going to check on Stephen Johnson. Is he still scheduled to go home today?
He's going home today.
Great.
He's been with us about 10 days now.
Will be.
I mean, doing okay. His recall of the injury, what happened to him, that remains quite vague for him. He's independent in the ward. He's up getting dressed and walking about independently. But saying that he is lying in bed most of the day, would lie in
Right.
the bed for about half of the day if we didn't prompt him to get up and out of bed. But I think that's because he's complaining of feeling really quite tired.
Right, is he still
Very
tired?
tired at the moment. Also complaining of headaches, which he's getting regular analgesia for. He's also complained about not being able to concentrate and watch TV programmes or read books.
Okay.
He feels as though he's losing track of things. But probably one of the more concerning things that came to light is that he's become much more irritable and agitated.
Ah, right, okay.
He's generally okay with the nursing staff and with other patients in the ward, but it's his wife that has said to me she's found him to be quite irritable,
Right.
quite agitated, and can become quite verbally angry and aggressive with her. She's
Okay.
been struggling to try and come up to the hospital. She's working full time. She's got 2 small children, but he can't see why she can't be there when he
Right,
wants
okay.
her to be there. So it can be a bit tactless with her at times, which she's finding really quite difficult and she's struggling a bit with.
So, just trying to get a feel of how long you're out of bed and how long you're in bed, would you say that you spend less than half the waking day in bed or out of bed?
I would probably say in bed.
Right. And that's completely out of character for you?
Yeah.
Okay. What do you do for work, Stephen?
I work in a construction office.
Okay.
yeah.
And what kind of job do you do? What is it
Oh,
you're
it's
doing there?
admin and wages and
Right.
kind of pay guy, I suppose.
Okay.
But yeah,
So it involves quite a bit of concentration then?
yes.
Have they said to you how long you should be taking off work?
Well, they've been pretty vocal about telling me that I should be very careful and not rushing back.
Right.
But I need to get back on Monday, to be honest.
That's quite quick. If you're spending most of the day in bed just now and going back to work on Monday, would you not
guess.
consider taking a bit longer off?
I would think about it, but I do need to get back.
Okay. When your family come up to visit you, for instance, are you quite sociable with them? Are you talking away to them quite normally?
Not the last couple of times. No, I didn't really
Really?
sort of say much to them.
What's been happening?
I've just been really kind of exhausted. Sort of haven't really been able to find the words to talk to them. Just really tired.
Do you think you're a bit more quick-tempered than normal? Like with your family or with your friends?
Yeah, I would say so.
Okay. Do you find yourself a bit more irritated?
Yeah.
Okay. Are you aggressive towards them?
I'm not aggressive. No, I wouldn't say I'm aggressive.
No?
Next, social and leisure activity is rated. This relates to engagement in leisure interests. On the ward, this can include reading newspapers or books, engaging in conversation with staff, other patients and with visitors, showing interest and preparedness to participate and interact. It can, of course, be the case that the social interactions are not appropriate and may be disruptive. The ratings then need to take account of this, and a range of outcomes from lower moderate disability to lower good recovery are possible. Next, we show an example of upper moderate disability.
Been here for about a week now, doing okay, completely independent with all his activities of daily living. He is napping quite a lot, lying in bed quite a lot. He says that's more to do with boredom being in the
Right,
ward,
okay.
but he is complaining of still feeling quite tired at times. Generally okay with family. Family have been up visiting him. He's relatively sociable with people in the ward, not hugely, but he does chat. Although the family have said he's been slightly more argumentative with them, and we have noticed that with some of the nursing staff occasionally, but it's, at the most once a day, if that. Physically, as I say, he's complaining of really feeling quite tired, napping a lot, and still complaining of headaches, requiring regular analgesia for that.
Right.
He's self-employed and plans to go back to work on Monday.
Okay.
So we've said, due to him still feeling quite tired, again, as I say, being a wee bit agitated and irritable with his family and the headaches, we've advised really to sort of grade himself back into work a bit slower than what he wants to do.
So since you've come to this ward, what have you been doing in a day? What would your typical day be here?
I've not really been doing like a great deal. I've been kind of resting up, I suppose.
Do you get out of bed in the morning and stay up all day?
I'm awake a lot of the day, but I do tend to sort of like stay in bed and nap, I guess.
Okay. Do the nurses have to come and prompt you and say, it's morning, Stephen, it's time to get up, to get washed, get dressed?
No, Not in the morning, but in the afternoon there was a couple of times. Well, yesterday they said it was lunchtime and I went back to bed.
Oh right, was that before lunch?
Yeah.
You went for a nap before lunch?
Mm.
What about after lunch? Did you stay up?
I stayed up for a little while and then again I went back to bed.
Okay, is that because you were really tired?
Yeah.
Or just because you're bored?
No, well, I mean, I am bored, but I am feeling quite like I haven't got as much energy, and I am very tired.
Okay, is that more than normal?
Yes.
In the daytime here, do you get visitors? Do they come up in the afternoon or do they just come up at night?
They come up at night time.
Right, and how are you with them?
I'm okay.
Have they noticed any change in you?
I think they think I'm hemmed in here, so they were. Yesterday I had a sort of a conversation with my partner, but it was just because I'm dying to get back. You know, I'm just a bit frustrated.
Right, just by being in here, just desperate to go home?
Yeah.
Okay. How are you getting on with other patients in the ward and interacting with the staff?
There's a guy that I talk to now and again in the other bed. I just feel a bit sort of like I haven't got anything to say to these people.
Okay.
I'm a bit tired.
The final section of the form takes account of other issues that are relevant to a return to normal life. These include the presence of persisting symptoms. People can have persisting symptoms or minor problems that trouble them and are judged as lower good recovery because these are likely to have a negative impact on daily living.
Hi Sharon, how are you?
Irene, I'm fine.
Great, just in to see Stephen Johnson.
Hi.
You should be going home today.
Yep.
Still the plan?
Yeah, absolutely no problems. Ready to go home. Wee bit of headache. Taking some paracetamol for it, but no problems, no concerns about it at all. I can go.
Brilliant. How many times would you say that you're lying in bed during the day, or how long for?
How many times? Probably 2 or 3 times over the last couple of days, and an hour and a half, sort of.
Yep, that's fine.
Sort of small nap.
When you're out of bed and you're walking around, is there anything that you've noticed that's giving you any bother?
Walking about, maybe a slight headache.
Okay. Would it be enough that you're having to take some medication for it?
I did. I got some paracetamol from the nurse
Right.
yesterday.
That's fine. Do you normally suffer from headaches?
No, I don't.
You don't normally take any medication for anything like
No.
that? No. And when you're lying in bed, it's a bit noisy in the ward. Does the noise bother you at all?
Not the noise, no.
No. When the sun, like today, is shining in the window, does that bother you?
It has been, yeah. It has been sort of affecting me a little bit, yeah.
What do you do then? Do you kind of close the blinds over?
I did pull the curtains, yeah.
And is that okay once you've done that?
Pretty much so, yeah.
Have you ever noticed anything like that before?
No,
So this is a new thing?
yes.
Okay. What about your memory and concentration? Have you noticed any change in that?
My memory's okay, but I was trying to read a newspaper earlier on, and I did go over the same page a couple of times.
Right, okay.
Sort of just not getting it, if you know what I mean.
Do you get fed up with it and just put it away? And
I
not
did
bother
that
with
time,
it?
yeah.
What about watching TV? Have you done much of that?
There's one in the corner, but I haven't looked at it.
Not really. Okay. So would you say that more when you're reading over things, you're having to do it a couple of times and that's out of the ordinary for you?
Yeah.
Remember, it is important to note at each step whether any problems you find were present before the hospital admission as prompted in the form. If they have no symptoms or complaints that are mild and do not seem to affect their daily life, they are judged as upper good recovery.
Just here to see Stephen Johnson? Is he desperate to get away?
He is, he is. We're just waiting on his family coming to get him. No problems at all. Absolutely
Great.
fine, can go.
Okay, that's great. I'll just go and see him and then come back and speak to you.
Okay, perfect.
Any problems at all that you've noticed?
Problems. I do have a slight headache.
Okay.
It feels a bit like a hangover.
Okay.
Yeah. But yeah,
Are the nurses giving you any medication for that?
no,
Nothing at all?
I haven't asked for it.
Okay. Are you up out of bed most of the day?
Yes,
Are you sitting watching TV, reading papers?
I'm reading.
Okay.
Yeah.
When you're reading, have you noticed any change in your concentration?
No.
Everything okay? Are you understanding what you're reading?
Yes. Yeah.
And are you able to read through a full paper or magazine without any
Yeah.
problems? Okay. Do you think you're any more tired than you normally would be?
I was a little tired this morning, so yeah, I
Okay.
didn't have the same energy.
Did it stop you from getting up and doing things?
No, it didn't.
No. You didn't have an extra lie in bed?
No, I
No.
didn't. No.
We hope that you've found this film helpful. To conclude, I'll briefly recap on a few points. The Glasgow Outcome at Discharge Scale is an assessment for adult inpatients with a traumatic brain injury who are near to discharge from hospital. The GODS can be used by professionals from a range of backgrounds. It is for use in assisting hospital discharge planning and decision making, or in audit or research studies. The GODS can be used with the Glasgow Outcome Scale extended to assess disability in hospital and community settings. The GODS is available free from the University of Glasgow website. Further information and data on the validity and reliability of the GODS are published in the Journal of Neurotrauma, and the brief written guidelines are to be found together with the GODS form on the University of Glasgow website.